lecture, we will cover the specimen collection and management of optimal recovery of microbial organisms within clinical microbiology. So for any specimen that is received into the lab, of course, it should be labeled. And so when collecting a specimen, you should always make sure that you properly identify the patient, or the phlebotomist should properly identify the patient before collecting the sample. If it's something like a wound culture or any other tissue culture or anything, then the physician may be the one to collect that. It should be labeled, and of course it should be labeled at bedside, at the patient's side. And it should contain all of the necessary information, as well as match the order that comes with it. So whether it's a paper requisition or an order in the computer, the information on the container, the collection container, should match that order and requisition. So for example, if the patient's name is spelled one particular way on the requisition, then it should also be spelled the same on the patient's sample. And sometimes you can have issues where a patient may go by a nickname, and so it may be written on the sample with the patient's nickname versus the given name. So those are things that need to be double checked by the person that is collecting and labeling the sample. And so on the sample itself, the sample is typically labeled with at least 2 identifiers, and it depends on the protocol for the facility as far as what they will accept. But typically something like the name and date of birth, or the name and hospital identification number or medical record number. So there should be 2 unique identifiers to that patient on the sample itself. However, most places have gone towards barcoded labels, so most of that information will print on it rather than being handwritten on that specimen. And so things that will come on the requisition will be things like the patient's name, the identification number, the patient's date of birth. Sometimes it will also include the age, the sex of the patient, the collection date and time, the order and physician, and where the specimen source is. So for example, a culture, if it just comes on a swab, you may not necessarily know where it comes from just because it's on the swab. So it could have been a throat culture, it could have been a nasal culture, it could have been a wound culture. So the specimen source is important so that you know what organisms you're potentially looking for as pathogens, and to know which culture media needs to be set up for those particular pathogens. The way specimens are collected is very important. You want to make sure that you're actually collecting during the acute phase of the illness, so this is when it's kind of rapidly onset. You also need to make sure that you're minimizing any sort of contamination from the normal flora. So with a throat culture, you just want to get the tonsil area, not necessarily the entire oral cavity. So you want to make sure that you stick to just the area where you're looking for the infectious organism. You should have collection material available to those that are collecting it, as well as specific instructions for the particular type of collection that is being performed. And so in some cases, the patient may be the person who's collecting the specimen, for example with a stool specimen, so those instructions should be very clearly written for those patients. And the collection should be completed prior to any sort of treatment, so before antibiotics are given or before any sort of antiviral or antifungal medications are started. Specimens should be transported to the lab usually within about 2 hours, just to make sure you can maintain the viability of that sample. However, if it is delayed, then there are different preservation techniques that can be used to help ensure that those organisms stay viable. And also the containers should be leak proof, and they should be transported in a biohazard bag, because you never know what sort of specimen as far as the pathogen in the specimen. So it could be something that could cross-contaminate something else, or it could leak out and be a hazard to those that are handling those bags. So you always want to make sure that you're avoiding any sort of contamination. Some of the different specimen preservations that are used for micro include boric acid for urine samples, and so you can see the yellow tube in the middle up under the ONP pack. So you have a yellow tube, it's a BD vacutainer, and so what that does is it has a little bit of the boric acid in it, and the purpose of the boric acid is to maintain the colony count so that those organisms don't overgrow before it has the opportunity to be cultured. With feces, you get the it's a buffered formalin that is in those packs, so you can see the parapack with that orange top at the top. And so that's an example of a collection container that may be sent home with the patient to collect. Then you have different holding medias like Stewart's and Amy's media. And so you can see some swabs in the lower right-hand corner, which are used for transport of some cultures. And so they have something in them to either prevent it from being exposed to air, or to provide some sort of extra nutrients, or to prevent the organisms themselves from drying out. With your blood cultures, you see those two bottles at the bottom that actually look like bottles. Your blood cultures typically have some sort of the SPS within the bottles that helps to preserve those organisms as well, and to help enhance their growth once it is loaded onto the analyzer. And then you can also have a heparin tube for, and it's not usually not an actual heparin tube, but it is a special tube for viral cultures, although you may not see viral cultures much within the lab. However, some of the things that should not be used would be EDTA tubes or ACD. And up in the top right-hand corner, you can see an example of the ACD tube. And so something like this should not be confused with those urine collection tubes that are also yellow. So with these tubes, they are for HLA typing in blood bank or different types of DNA and genetic studies. So making sure that you use the proper tube is very important, and if you're ever in question, you always need to pull the specimen label back with the patient's name on it, just to make sure that the label on that tube is adequate for that particular specimen or culture that you are performing. Specimens that are not processed immediately can be stored, and dependent on the particular specimen and what organisms you're looking for will depend on the temperature. And so a lot of it will be dependent on if there's transport media involved as well. And so there is a chart in the book, table 5-1, that lists various specimens and what the storage requirement or the transport media that's acceptable for that particular specimen. And so, and it can be dependent too on exactly what organism you're looking for. And so depending on that, which you'll learn a little bit more detail about this once we actually start getting into those organisms, you will learn a little bit about which ones are more temperamental. And so depending on the specimen, it could be stored refrigerated, at room temperature, body temperature, or even frozen. So there are situations in which specimens would be rejected, although with micro, it is a little bit harder to recollect specimens, but with these situations when specimens need to be rejected, then that's something that may need to be discussed with the physician or the pathologist of the lab to determine if indeed you should proceed with that specimen. But typically the things for which a specimen would be rejected would be if it's mislabeled, if it has the wrong patient's name on it. So those would be rejected and need to be recollected. If it's not properly transported, so if it was stored at the wrong temperature, it was collected with the wrong swab, or if it was put in the wrong collection media, if it's been set in, got lost in the courier's car overnight and it's been sitting in the car in the hot for 24, 48 hours, then that specimen obviously couldn't be cultured, because those organisms would either have a lot of overgrowth, or depending on the temperature, it could have destroyed those organisms and it could have dried out. If there's not enough specimen to perform the culture, if the specimen has leaked inside of the bag, it could have been possibly contaminated. If it's in a fixative, of course this will vary by the specimen type, but some fixatives will destroy the bacteria. If it's an anaerobic culture that's requested, but the specimen that was sent, or the particular source that's listed on that culture, is known to have anaerobic organisms as the normal flora. And so an example of this would be a vaginal culture, where there are anaerobic organisms that live within the genitalia vaginal tract. So ordering an anaerobic culture on that particular source means that you're going to recover normal anaerobic flora. And if you get the specimen and it's dried out, then obviously it's not going to grow anything if those organisms have dried out and died. Once the specimen is received into the lab, it should be documented with the date and time that it arrived. And so this is important, so you can compare with the collection date, with the received date, if there's any discrepancies in anything, and also to be able to track the specimen as far as when it was received and when it was actually cultured, when the results were sent out. So it kind of gives you a time frame on the specimen. Priority is always given to the most critical specimens. So for example, a spinal fluid is always considered a very critical specimen, and so those usually processed right away as soon as they come into the lab. You will also examine the specimen itself, and so when you do that, you may make a manual or an electronic record of that specimen as far as what that specimen looks like, or if there's any kind of issues with the specimen once it arrived to the lab. And when you perform the culture, you will want to make sure that you're looking for the bloody mucoid areas, depending on the specimen, to make sure with those mucoid areas or a pus type area of that specimen that you're most likely getting a bulk of those organisms. And so you do want to try to get those areas included as well. With a direct microscopic examination, you're preparing a slide directly from the specimen source. So for example, a sputum culture would come in a cup with the sputum actually in the cup. So you would make a slide off of that sputum sample. You would roll that onto a glass slide. And so what these type of examinations do, so rather than taking it directly from the culture and looking at the organism, you're looking directly of what come from the patient. You're being able to assess the quality of the specimen. So with sputum cultures, you're looking for a quantitation of white blood cells, epithelial cells, to see if it's possibly contaminated. It also will give an early indication of what can be going on with the patient. So for an example with the spinal fluid, if you perform a direct examination of that spinal fluid and you see gram-positive cocci within that spinal fluid, then that gives the physician an early indication that there is some sort of gram-positive cocci organism that's growing within the patient, so they can go ahead and start treatment with antibiotics that target that particular organism. And you're also looking to see if what you saw on the actual gram stain matches with what you're actually getting in your culture. So if that spinal fluid showed gram-positive cocci, but when your culture grows you don't see any organisms, or let's say you see a gram-negative, then something somewhere in that process went wrong, so it needs to be investigated. Now, depending on the specimen type that is submitted and the location that specimen was collected from, you could potentially be required to do an initial microscopic examination or a direct gram stain of that specimen. And what this will do will assess the specimen quality. You're looking for the presence of neutrophils and epithelial cells, which would signify an infection or contamination based off of the particular quantity of those cells. Also, that direct stain will provide clues towards the preliminary identification, and it will guide in the workup. So in other words, depending on what you're seeing in that gram stain may kind of point the direction of the workup and how you would take that workup. So for example, you're looking at that gram stain to look at the morphology of the bacteria to determine if they're gram-positive or gram-negative, cocci or bacilli, chains, pairs, clusters. If it's suspect, looks like maybe it's anaerobic, or if it looks like it's got fungal elements in it, then these are all things that will kind of give you a preliminary idea of what you're dealing with. Now, another way that you could kind of go with that is if you would typically set up certain media for that particular culture, but you see an organism in there that doesn't look like it's would typically be fine there, and maybe the media that you would typically use isn't going to support it, so maybe you would throw in an extra plate to try to catch that particular organism that you're seeing. Now, your primary media selection that you're going to set your culture up on is going to be determined on a variety of things, the particular media, the culture that you're setting up, and what you're trying to grow. Now, culture media itself does provide nutrients that are required by the microorganism to grow, and so it's going to provide various energy sources and buffers into that media that will do things like enhance its growth, decrease the viability of other organisms. It could have various dyes and antibiotics that are placed in it. So it's just going to be kind of designed to basically choose or pick and choose the particular bacteria that's going to grow and how it's going to support that growth. And then some of the energy sources that are provided are going to be things like carbon, nitrogen, sulfur, phosphorus, hydrogen, oxygen. Now, your media can come in a broth type liquid media base. It could come in a agar, you're going to hear this pronounced a couple of different ways, which is a gel semi-solid type of media. It's made out of agarose. You also have biphasic type media, and so it contains both a broth and a solid type of media in it. And so an example of this would be your blood culture bottles, where you have that more solidified media in the bottom of that blood culture bottle, and then you have that liquid media up top. Now, cells grow as colonies by multiplying exponentially. This means that individual colonies will actually have very distinct characteristics, and within those colonies you have multiple organisms that live and reside in that one little colony. Now, all testing that you are going to perform will be off of an isolated individual colony. So when we say isolated, it means that that looks like it's only one organism that's growing in that group. You don't have any other organisms touching it or any other colonies touching it. So you're just working from that one little circular type of colony. Primary plating media is selected based on, like I said, the specimen type, the site, the growth needs of that particular organism that you expect to find as a pathogen in that particular site. Now you need to have isolated colonies for those biochemical and serological testing, or if you're going to do any sort of subculture or anything, because if you're testing, when you're testing isolated colonies, you're testing just the particular organisms in that particular family that are growing in that colony. Versus if it's not isolated, you might be picking up another organism, and so you're going to get mixed results or invalid results when you're testing because you're testing multiple organisms that have different characteristics. So you always want to be cautious to make sure you're working with just one particular colony when you're doing these biochemical tests. With your culture media, you have several types of culture media. And so they can be divided into categories. So you have a supportive media which supports the growth of a wide range of microorganisms. And so this would be something like blood agar or chocolate agar. And you can see an example of that in the top left-hand corner where you have a blood agar plate. You also have differential media. And so what this does is it helps to differentiate one organism from another just based on certain characteristics that that organism has. You also have selective media, which supports one particular group of organisms over another. So for example, it may support gram-negative organisms versus gram-positive organisms. And this is done by using some sort of dyes or antibiotics or other chemical compounds that inhibit the growth of the one organism but allows the others. And then sometimes you can have media that is both selective and differential. So for example, at the bottom left-hand corner, you see a McConkey plate. And so what this does is it allows the growth of gram-negative organisms. And it also is differential because it will differentiate the lactose fermenters from the non-lactose fermenters. So your lactose fermenters produce that pinkish purple color, whereas the non-lactose fermenters will stay kind of that clearish color. You can also have backup broths, which can be supplemental or enrichment. And so this is typically used in conjunction with your solid media, and it can help to detect when there's just a small number of organisms in that culture swab or whatever specimen has been submitted. Then it kind of helps to enhance that growth of those small organisms. And so sometimes something like this may be set up on like a vaginal culture would be an example, in which it would allow for an enhancement growth of those organisms. And then that broth itself can also be cultured or gram stained as well. Some examples of your non-selective or enriched media are going to include your blood agar plates. And this is what you're going to use primarily in micro. Pretty much every specimen you set up will have some sort of blood agar plate. And so within your blood agar plate, you've got this mixture of things, the tryptase soy agar with a 5% type of red blood cells that's added in. We prefer sheep blood agar because your horse and your rabbit blood can give different results. So sheep blood agar is generally what is used within the U.S., and it will grow the most significant pathogens. Now, on that sheep blood agar, we're looking for something called hemolysis, and you're going to observe this on the surface of the agar, or for some cases you might do a stab into that agar and you're looking for the subsurface hemolysis. And what we're looking for is if an organism is alpha, beta, or what we call gamma, or no hemolysis. And so what you're looking for with alpha hemolysis is a incomplete clearing or a greening or browning of that agar. So you can see here in your images where you've got that alpha hemolysis here. So you have that green clearing. Now, if you're ever unsure, you can actually take like a culture loop and just kind of scooch the colony over to the side and just look at the agar itself and see what it looks like under that particular organism. Because sometimes the clearing can be taking place, but it's under the organism. So you could kind of scooch it to the side and look at the clearing of the agar if you're unsure. But typically you can just hold it up to a light source, hold it up to the sky, and kind of look through the agar and look for that clearing. Your beta clearing is going to be a complete clearing, so you can see where it's almost like a yellowing clearing where it has hemolyzed that sheep blood in there. And then gamma, of course, it has no hemolysis of those cells, so you can see here where you just have the presence of the colonies, but you don't actually have any sort of clearing. So again, these two up the top here, this would be your gamma, and then here we have our beta, where you got that complete clearing, and then you have your alpha here, where you've got just a partial clearing of, or that greening of those cells. Chocolate agar, it does use red blood cells, but they are hemolyzed by an enzyme or a heat that will allow it to release NAD and hemetin. And so what that means is that there are certain organisms that are fastidious and they need that in order to grow. So an example of this will be Haemophilus. So we'll learn a little bit more about these when we talk about these individual organisms. But because of their growth requirements, they can't grow on sheep blood agar unless there's certain circumstances. So when we suspect a culture will have these particular organisms in it, then we will be sure to set up a sheep blood agar, a chocolate agar, which, as it implies, it actually looks like chocolate on a plate. Your differential media is going to provide a distinct appearance to that colony based off of the various elements that are within that agar. What it will do is that it will isolate one particular group of bacteria. So for example, this particular agar here will isolate gram-negative organisms. So if there's anything that's gram-positive, it won't grow on here. So typically we refer to this as selective and differential media because it is selective for particular organisms, and then it will actually differentiate those organisms based on characteristics. So here we have an example of your McConkey agar. McConkey agar has this pinkish purplish hue to it before you inoculate it. And what it will do is actually isolate your gram-negative bacteria, and then it will differentiate them based on their ability to ferment lactose. So the agar itself contains lactose, and then if the organism itself is able to ferment it, then it will turn this really pretty pink color. So you're actually looking at the color of the colony, not the agar here. If it's a non-lactose fermenter, it would be clear. So you would just see the presence of the agar growing, and then the agar itself would have this kind of lavender pinkish type of look to it, so the colony would typically be kind of clear and kind of appear about the same color as it would, as the agar would. E and B agar, so this agar has some particular dyes and things in it that will help to isolate that gram-negative bacteria. And then again, it's going to differentiate some of the organisms that can ferment the particular lactose versus ones that cannot ferment. So if the organism is a strong lactose fermenter, then it will actually produce this metallic sheen that you see here. It's really pretty. If you kind of rotate and tilt the plate when you're looking at it, you can see that metallic sheen. Otherwise, if it just ferments lactose, it will be more this darker purple color here. So both of these will indicate that it does ferment lactose, but when you see that little green sheen to it, you know that it is a very strong lactose fermenter, which is going to indicate that it is most likely going to be E. coli. Your non-lactose fermenters, of course, would just have the clear colony, so it actually kind of appears more of like a clear reddish pink color when it's growing on that plate. Enrichment broths will inhibit the growth of one group of organisms, but enhance the growth of another. So for example, gram-negative broths, a lot of these broths are used to inhibit the normal microbiota of the colon, but it will allow for the enhancement of growth of the various stool pathogens. Your thio broth will be used to differentiate aerobes and anaerobes. So these broths, they're just liquid media that's in a tube of some sort. When you put the specimen in there and it grows, it will kind of give you a picture of where that organism will grow. So where you see that cloudiness and that thickness to that organism, will indicate exactly how aerotolerant it is. You know, is it an anaerobe or is it an aerobe? So you'd put that cap on loosely, and then the oxygen would kind of seep into it. So depending on where it grows, if it grows just up top here, obligate aerobe. Just at the bottom, obviously there's no oxygen down here in the bottom of this broth. All the oxygen is going to be up top. So if it grows at the bottom, then you can determine that it's an anaerobe. Facultative anaerobes, you can see where it's kind of just growing throughout that broth, a little bit more at the top, and then aerotolerant anaerobe, it's growing throughout that broth pretty evenly. Selective media, so it is going to be designed to inhibit the growth of all the bacteria except the particular one that you're looking for. So examples of this would be when we're using the culture media for stool cultures where we're looking for some of those pathogens like your Salmonella, Shigella. So the media will actually inhibit the normal bacteria that grow in the colon and then enhance and isolate the stool pathogens, and then it will actually help you to differentiate the particular stool pathogens based off of their ability to ferment the different carbohydrates as well as the ability to produce H2S. And that H2S is going to give you that blackening that you see taking place here. So with your HE agar, that's like a greenish type of color to that or pigment to that agar. And then based off of those colony characteristics, so in this particular example here, the pathogen is your colorless colony here for the Shigella. You can see where the Salmonella species did that darkening, and where that would mean that it is H2S positive, where the Shigella is H2S negative. Your XLD media, you can see where it just kind of differentiates your Salmonella with that H2S production. And then your Shigella has those clearer, pinker colonies based on that agar. And then Proteus kind of gives that yellowing around the outside edge of that colony. And then your other agar that we have here is your Salmonella Shigella agar. So you can see that your Shigella colonies are kind of clear growing versus your Salmonella where that H2S is produced and you have that blackening color. So if you see that blackening color on these agars, that means that H2S production is there and you're dealing with a Salmonella species. Your antibiotic media, this particular media will have some sort of antibiotic in it that will inhibit the growth of some of the other different various organisms. So for example, your CNA agar, it's basically a blood agar, but it has antibiotics in it, so it will grow gram-positive bacteria but inhibits the growth of gram-negative. So if you have a specimen, let's just say for example a urine specimen where you know that you've got the potential for gram-positive and gram-negative, you would start off with a blood agar plate, probably put in a CNA plate possibly. There are some other medias that could be chosen instead, but you could choose to do a CNA to grow your gram-positives, and then your McConkey agar to grow your gram-negatives. Your modified Thea-Martin or your Martin Lewis is a chocolate based agar that has antibiotics added, and what this will do is help to select for the Neisseria gonorrhea, and it will actually inhibit the gram-positive bacteria and other gram-negative bacteria as well as yeast. So depending on which organism or pathogen you're looking for in a particular sample will depend on where you actually incubate those agar plates. So if you're looking for an aerobic type organism, these are incubated within an ambient air, and so this would go directly into the incubator with an oxygen of about 21% with a very low CO2. Your anaerobes cannot grow in the presence of O2, so those would go into some sort of like an anaerobic bag to prevent any sort of exposure to O2. Your capnophils require an increased CO2 with about a 15% O2 level. And then your microaerophils will grow under reduced O2 levels but increased CO2 levels. And so most of your medically relevant bacteria are facultative anaerobic bacteria, and so they can grow aerobic or anaerobic. Your temperature, most of your relevant organisms will grow between 35-37 degrees. And of course, with your funguses, we already covered that those have a pretty a lower range as far as where they grow at. So with working up specimens or reading culture plates and identifying organisms within microbe, you can have limited identification in which you just kind of work it up to the genus but not the species, versus a complete identification where you're actually working it up to the point of narrowing it down to the particular species. With your presumptive identification, use a small batch of tests and presume an organism to be a particular organism based on those tests. So you're not going to do a complete workup, or it may be a presumptive identification for a preliminary workup before you do the additional automated type testing. With a definitive identification, you're also including the antimicrobial susceptibility testing. So typically this may be something that's going to be put on an analyzer, so not only does it have all the biochemical tests, it also has the antimicrobial sensitivity testing as well. You also need to be able to differentiate the normal flora versus a pathogen, and so an example of this would be a stool culture in which you have normal microbiota within the intestinal tract, and so you need to be able to differentiate that which bacteria is normal versus something that may be a pathogen like Salmonella or Shigella. Critical values in micro includes bacteria growing in a blood culture, spinal fluid, finding something like a parasite, malaria in a blood smear, thick or thin, finding acid-fast bacteria, certain biological agents that you'll learn about in the future that are always considered a critical result, and some of those do have to be reported to the CDC. Anaerobes are considered a critical value. So with any of these, once it's found, it would need to be called and notified to the physician. So if you're doing a spinal fluid in the micro lab and you do a gram stain and you see organisms in that gram stain, then you need to call the physician and alert them versus reporting it in the computer. Something like a urine culture would just be reported in the computer and the physician would get the results and see the results versus having to call a urine result. Now, just like all the other areas of the lab, the microbiology department is required to do quality control within that department. And this will include things like the monitoring of the laboratory equipment. So checking your temperatures daily of your incubators, refrigerators, freezers, any sort of water baths or heating blocks. Looking at the concentration of the gases that are used, your autoclave, if you use an autoclave, just doing those daily checks to make sure those things are working properly. Part of quality control within a laboratory is making sure that there is a procedure manual in place and ensuring that personnel go through an orientation and training, as well as safety training, any sort of training when new instruments or methods are brought into the lab, and also continuous education and professional development. Microbiology departments will also do quality control on the media and reagents that's used, as well as the various analyzers that are used within that department. Now, for your culture media and reagents, you have to test each new shipment with some sort of quality control organism. So these are organisms that are maintained as stock cultures. And then you would use them to actually set up the various culture media and perform the various tests to make sure that you get adequate positive and negative results for that particular test method or that media that is used. Some terms that you should be familiar with are pathogens, which is a microorganism that causes an infection or disease. Virulence factors, these are characteristics that help the microorganisms to cause the particular disease. Pathogenicity and virulence is the degree to which the microorganism can cause a disease. Opportunistic pathogens or infections. These are infections that happen when one or more of the host's defense mechanisms is disrupted, and then the infection is able to happen because the organism that typically resides in the individual is normal microbacteria, microbiome, and actually infect the patient at a site that is not supposed to be in. So here's some of the different virulence factors. Attachment is when the organism is able to outcompete colonizers and adhere to the surface. Invasion, usually by some sort of traumatic factor or due to the other virulence factors, the organism is able to disseminate into the deeper tissue. Survival against inflammation, and they do this by avoiding being phagocytized and by being recognized by the complement system. Survival against the immune system, or they can produce toxins. With endotoxins, it is actually in the cell wall of the usually gram-negative bacteria, and so once the organism dies, then those endotoxins are released from that organism to the surrounding tissue. With exotoxins, the organism, usually gram-positive bacteria, actually releases, it produces and releases that exotoxin. Some mediators of pathogenesis include a pathogenicity island or a biofilm formation. And so with your biofilm formation, there's an accumulation of the monomicrobic or polymicrobic population, so one organism or multiple organisms that will start to provide a protective environment for the organisms that live in that little cluster. So here you can see an example where number one, the organism attaches, and then from there it will start kind of building this little protective network, and the organisms will just continue to replicate and grow, and then as that protective network gets bigger, then those organisms can be released, and then they'll go and start their own new attachment and new colony. So the outcome of a patient with any sort of infectious organism will depend on a couple of different things. The state of the host's health, so how their immune system is, how it responds, their overall general health, the virulence of the particular pathogen that is the cause of the infection, whether or not the host can actually clear that pathogen. And so you do have three types of infection. You have an acute infection, which develops very quickly. Chronic infections develop slower, usually over an extended period of time. And you also have latent infections in which the organism can actually go into like a silent type phase where you don't have any sort of symptoms that present. Some of the signs and symptoms that can indicate an infection would include aches, pains, headaches, fever, swollen lymph nodes, rashes, any sort of sign of inflammation like redness, swelling, or heat at the site, coughing, sneezing, congestion, sore throat, nausea, vomiting, diarrhea. So a lot of these can indicate many illnesses, but it can also be a sign of an infection from a microorganism. So when we look into preventing infectious diseases, we look at a variety of things. So we look at different strategies to prevent transmission, to control the microbial reservoirs, and to minimize the risk before and after exposure. So some of these things could include just good hygiene, washing your hands, some of the things that happen within surgical operating rooms now as far as how they scrub in, how they scrub out, making sure that the instruments are cleaned properly. Some circumstances it may be that you're using disposable type materials now to prevent any kind of infection or hospital-acquired infections, and just things that you kind of use with your daily life of, preparing your food when you're cooking chicken, making sure that you prevent any kind of contamination off of that chicken, properly preparing your chicken so that you kill any kind of potential microorganisms that you could get through any sort of like foodborne illness. You can also use vaccines, immunizations to prevent infections, and so it can be active, which, this is typically what we think about for our immunizations, where it's something that's been modified and it's introduced into the body, and then there builds up a immune response. And so an example of this would be like a pneumococcal vaccine. And then you also have passive antibodies that are transferred temporarily. So this would be something like a mother passing to an infant, the antibodies that pass to an infant before the baby's born, and then the antibodies that are passed through breast milk. And with epidemiology, this is the science that characterizes the circumstances associated with how infectious diseases are acquired and how they are spread. So that's what the epidemiology field looks at, is the different infections and as well as ways to prevent those infections. Some of the various specimen types that you will see in microbiology, we're just going to kind of briefly cover those and just kind of briefly talk about where that specimen type is coming from and what we're looking for. So with upper respiratory tract infections, we're going to look at a couple of different things. So throat specimens, typically the infections that are going to infect the throat will be some sort of viral infection. Strep infection, particularly strep pyogenes with a group A streptococcus, as well as yeast infections. There are a few other things, but these are going to be the most common. Your specimen collection is going to be from the posterior pharynx. So this will be all collected and sent to you, but you are going to collect around that tonsil area. Avoid any of the normal flora that could be there, so you don't want to be culturing the teeth as well. And typically they are going to collect 2 swabs. So the first, one of the swabs will be placed into a sterile culture media container, and then that will be sent to the lab, and then the other may be used to actually do a rapid group A streptococcal antigen testing. With your nasopharyngeal, this is usually going to be looking for those upper respiratory tract infections like abortotelepetesis, flu virus, coronavirus. And those specimens are going to be obtained using a very thin, flexible wire swab that will actually be guided along the nares to the posterior pharynx. And so basically it's kind of going way back on the basement of that nasal path, way back. Once you get tears and you've reached the brain, you've hit the right spot. Another swab that could be done on the nasopharyngeal area would be to check for patients that could potentially be in a carrier state for Staph aureus and Neisseria meningitis or meningitis. And what you're looking for is to see if they harbor that particular organism, and looking to see if someone is a carrier of MRSA. Other upper respiratory tract specimens could include the oral cavity, so looking for causative agents of things like gingivitis and dental caries. And so these are just various infections that can happen within the oral cavity, within the teeth and the gum line and things. Middle ear infections, looking for particular pathogens. Rarely cultured here. It's usually going to be more or less if you've got an individual that keeps getting the ear infections and the antibiotic treatment's not working, and if they're looking to see if it's something that maybe has some sort of resistance to that bacteria. Sinus infection, you can get you could potentially get some sort of direct sinus aspiration or wash. And what this is going to do is help to locate any particular pathogens It's not often you'll do cultures for sinuses, but maybe it might be a situation where an infection's not resolving. Maybe they think that it's some kind of fungus ball that's located in there, so maybe fungus cultures will be ordered. So occasionally you could see cultures for sinuses. CSF, or cerebral spinal fluid, we're looking for something that could potentially be causing meningitis. So this would be looking for things like Neisseria meningitis, Haemophilus influenza, Streptococcus, various viruses, and fungi like yeast. Collection will be performed using a needle aspiration from the third or fourth lumbar vertebrae. They will collect at minimum 3 tubes. A lot of times it will depend on the patient as well. Obviously with an infant or a child, they're not going to get as much as they would for an adult. But they usually are going to collect multiple tubes, and depending on the particular test that is being ran will depend on which department gets which tube. But typically micro is going to get that last tube. That way that you've got any potential for contamination out of the way. These specimens are considered stat specimens, so if a CSF comes into the lab, you are going to process it immediately. So you're going to have to find a stopping place for what you're doing to address the specimen quickly. And that's just to maintain the viability of it, and plus too, if you're doing a spinal fluid, it's a pretty serious infection that can be life-threatening, so it would be an emergency to get those results out. Lower respiratory tract specimens. So these are looking for those deeper secretions more in the lung. And so what we're looking for are looking for diagnosis of things like bronchitis or pneumonia, trying to figure out what particular organisms are causing that. It could be viral, it could be various microbial organisms like strep, various gram-negatives, as well as a mycoplasma pneumoniae. Specimen collection is going to usually be some sort of sputum specimen or some sort of aspirate or bronchial lavage that takes place within that lung. With your sputum cultures there, your gram stain evaluation is also going to include the enumeration of your neutrophils as well as your squamous epithelial cells. And this is kind of acts as like a quality control to make sure that you got a good quality specimen, and that your that specimen has not been contaminated with like other oral fluid, saliva, things like that. You know, you'd want to be testing the fluid that's coming from deep in the lungs, and not fluid from the throat or oral cavity, saliva, things like that. So what you're looking for is you're actually looking at the number of white blood cells or the number of neutrophils that you see. And then you're looking for the number of epithelials. So depending on what that score is, if you have, so what you actually do is actually do the quantitation of these this criteria, count your number of neutrophils and count the number of epithelial cells. So typically they're going to say if you tally those scores up and you got a score of 0 or less, then that's going to indicate that there's a lack of inflammation and there's presence of saliva in that specimen. And so you would need to possibly get a recollect. So your lab that you work for is going to have specific criteria for this based off of your lab and your standards for your lab, but it will look something like this. So they may say that if you have X number of epithelials per low power fields, then you need to suggest that it was contaminated. Gastrointestinal specimens, so this is typically going to be looking for some sort of a cause for gastroenteritis, which could be done by viruses, parasites, bacteria. So making sure you understand the patient's history, or the clinician gets the patient's history to kind of narrow down what they think it might be. That could help potentially to think, you know, to be able to figure out if it's potential food poisoning case or a virus, or whether it's actually something that may need treating. So the specimens, of course, are going to be stool, feces. Gram stains may be done on the specimen just to look for the presence of white blood cells, and you could add it to an enrichment broth to help to enrich those pathogens and to get rid of that normal flora. And so we're going to be looking for things that are causing infection like Salmonella, Shigella, Campi, Vibrio, and we'll learn more about these as we get further into discussing the various organisms. With the genital tract, we're looking for things like trichomonas, chlamydia, herpes, Neisseria gonorrhea, syphilis. The sample from these will be from any sort of exudates that are coming from the patient, so urethral exudates, urine, urethra, cervical specimens, the specimens from the uterus or the cervix area. And there are some methods now that can actually test for some of these using urine for PCR testing. So you may start seeing that in some of your laboratory when you're doing your clinical rotations, that you see some newer methodologies that are actually doing PCR testing. If you suspect that a patient has Neisseria gonorrhea, then you, or if the clinician suspects it, then you're probably going to get that specimen submitted in a Martin Lewis or modified Thea-Martin type of media. Urine specimens, we're looking for some sort of infection with the urinary tract. Of course, you've got mixed organisms of gram-positive and gram-negative that can cause infections here. And you potentially could also, if a urine is submitted to the lab, trichomonas could potentially be in there, but it's not really going to grow on your plate. So hopefully that was caught if the urine specimen was done in urinalysis and a microscopic was performed. Specimens should be clean catch midstream, or you could have things like catheters, subpubic aspirations, various things like that that are submitted, as well as sometimes you will actually get the catheter tip. You want to use a 1 ml calibrated inoculating loop, incubate for 24 hours or 18 to 24 hours depending on what your facility's procedure is, and then you're going to perform a colony count. Now that colony count, we did practice this in our lab math course, so you would, based off of the particular loop that you use, will indicate how you will actually quantitate that particular urine specimen. Blood specimens, you're looking for any sort of bacteremia within the patient. It could be in a transient state, intermittent, and continuous state. We're trying to avoid any sort of septicemia or diagnose any kind of septicemia, diagnose that sepsis, and hopefully avoid septic shock. Some of the various organisms that we're looking for include gram-positive and gram-negative organisms. To collect those specimens, you want to make sure that you properly clean the skin because you want to avoid any sort of contamination with the normal skin flora. You're going to use an alcohol type of cleaner, as well as, depending on the site that you're at, it could be an iodine-based type of cleaner as well. It's really going to depend on the site and their preferences what they use for those blood cultures, but it's going to use alcohol as well as some other type of sterile cleaner for the skin surface. You will collect at 2 different sites. So what this will do will hopefully avoid any sort of contamination that could be coming from the site itself. You're going to do them at least an hour apart, just to kind of give you an idea of that bacterial growth. So it could be the fact that the bacteria just waiting that additional hour could allow some of that bacteria to kind of grow and excel a little bit more in numbers and then be easier to detect. You want to collect at least 20 mLs per blood collection set, but usually no more than 3 sets will be done within 24 hours. This is one of those things that the labs will keep check on as part of their quality observations that they perform, is looking at the amount of blood cultures that are ordered and set up, because it is a very costly test and very time consuming because those bottles have to be incubated for so many days. Wounds and abscesses. So with these particular specimens, of course, it can be a variety of organisms that cause these infections, including gram-positive, gram-negative. anaerobes. If it's a deep tissue, deep within the body cavities, then you can somewhat assume it's probably going to be an anaerobe, as well as you could have various fungal contaminants that have gotten into that sore or gotten into that wound or abscess and caused issues as well. The specimen could be collected via an aspirate, collecting the fluids, the drainage, the tissue. You sometimes may even get, if they've done surgery on, let's just say, a diabetic patient, and maybe they're starting to lose like the pinky toe or something, it could be a situation where you get a whole toe or a whole limb in the lab to actually work up and do those cultures. It is recommended that for like your aspirates that you do use a needle aspirate just to maintain the viability of those anaerobic organisms, rather than using a swab. Occasionally you will have providers that will submit an anaerobic culture and an anaerobic swab. And so you just risk the probability of those organisms not being viable once you set them up.